And we are right now, you may go ahead.
A very good evening to dear delegates. We have joined here for the KCIAPM PATH webinar season 2. Today we have an eminent speaker with us, Dr. Anuradha. Before I introduce ma'am, uh, uh, may I let you all know that APCON is being conducted at Ramaya College from November 30th to December 4, and the abstract submission is over. The deadline for abstract submission. We are working on the abstracts, and by 30th of October, we'll let you know the results. Before we go into the webinar today, I'll briefly introduce ma'am. Dr. Anuradha ma'am is Professor, Department of Pathology at Yenepoya Medical College, Mangalore. She is passionate about pathology and has experience of 25 years in histopathology and cytology, with specific interests in nephropathology, oncopathology, dermatopathology, bone and female genital tract pathology. Madam has presented about 20 presentations as faculty in various conferences in India. She has about 67 publications in various national and international journals. Ma'am is recipient of Good Teacher Awards multiple times at KMC Manipal. Ma'am has participated in several conferences, workshops, and CMEs in India and abroad as well. Ma'am is actively involved in interdepartmental and intra-departmental research projects, guiding about 21 research projects and 58 poster paper presentations. Ma'am is keenly involved in inculcating an interest in pathology in clinical peers and students, undergraduates, and postgraduates. Ma'am is a member review board of national publications. Ma'am has about 24 years of work experience. She's worked at KMC Manipal and currently working at Yenepoya Medical College. Ma'am has successfully completed the ISN ANIO Clinical Nephropathology Certificate Program conducted by the International Society of Nephrology in 2014. She's also completed the Advanced Clinical Nephropathology Certificate Program. Ma'am has completed 2-week observership in renal pathology under the guidance of Dr. Mahesha at Manipal Hospital, Bangalore in 2017. Ma'am has done her MBBS from Government Stanley Medical College in 1991, MD from Kasturba Medical College, Manipal, and DNB Pathology from the Diplomate of National Board in 1996. So this is brief CV of ma'am, and presenting to you Dr. Anuradha ma'am. Ma'am, the stage is yours.
Yeah, thank you so much. We will, I'll share the presentation now, and we will start with our webinar right away. So I'm talking on diagnostic approach to soft tissue tumors. So the first thing is whenever we receive a biopsy, what we need to know is what does the oncologist or the oncosurgeon want from us, the pathologist. So most principally, he needs to know whether what he thought as location of the tumor, clinico-radiologically, whether it's the same on the histopathological slide, that is confirmation of the site, in the depth, whether it's really superficial or is it looking superficial, but it's actually deep-seated. Then classify the tumors into benign, intermediate, as well as malignant. That's because the treatment differs for all these. Benign, as we know, the treatment is excision, whereas intermediate, it depends on whether it's locally aggressive, recurrent tumor, which is non-metastasizing, or early metastasizing tumor. So if it's locally, for both, it's actually wide excision, but in rarely metastasizing, you need to follow up the patient. Moreover, whenever we call it as malignant, then he needs to know the grade and the margins for clearance, because he has to decide on the treatment. So based on that, he'll either do an excision with that neoadjuvant therapy, or radical excision followed by adjuvant therapy. Now, one more thing of late, which is very, very important, is that molecular study is required because targeted therapy has started for many of the tumors. So first is what are the types of specimens we receive in the pathology department. So we need, we receive first is core needle biopsy, especially done if the tumors are say clinically malignant and they need to know the histological grade, etc. That's when they do the core needle biopsy. Now, open surgical biopsy is usually avoided, but then if the core needle biopsy is not representative, or if it's not giving much of pathological idea about what exactly the tumor and its grade is, then they go in for an open surgical biopsy. Finally, we have the so sorry for that. Finally, we have the excision. Now, in excision, there are different types. It depends on whether it's benign or malignant. Now, if it's benign, then you just locally excise. Now, malignant ones, there are different types of excision. You have the intralesional, the marginal, the wide, and the radical resection. Intralesional is that it's grossly and microscopically, the margin passes through the tumor, whereas marginal, grossly it doesn't, but microscopically it may pass. In that case, we have to switch over to intralesional. Now, wide is when more amount of, besides the pseudocapsule, your normal tissue is also removed along with it. Radical resection is when, much more tissue is removed, that is normal tissue is removed. It could be intracompartmental, or it could be really wide when they do en bloc resection, as well as intercompartmental. Now, this depends actually based on the tumor size, the histology, and the adjacent normal structures. Now, excision specimens, when we receive, what is it that we need to do? So first of all, we need to review the biopsy slide and confirm the diagnosis. Then staging and grading of tumor, whether it's the same, meaning that supposing the biopsy shows, a low grade, then in that case, and this is showing a higher grade, it's very, very important for the clinician. So staging and grading of tumor again has to be done. Then assess the resected margins, and ancillary testing should be done in case it's not been done on biopsy and no preoperative chemo or radiotherapy has been given. In treated patients, we basically have to assess the residual viable tumor. IHC as well as classification should not be done ideally on these, but then in some cases we may have to do if it's the treatment has been done elsewhere and we are not aware of it. Now, we have come across the latest WHO classification, that is the 5th edition, and there are 11 distinct groups in that. I will not be going into the detail. So these are adipocytic, fibroblastic, and myofibroblastic, fibrohistiocytic, vascular pericytic, smooth muscle, skeletal muscle, then the GIST, that is the gastrointestinal stromal tumors, chondroosseous, peripheral nerve sheath tumors, and tumors of uncertain differentiation. Now, all these classification, that is the latest one, and the newer entries have been described beautifully in this review article. And according to the review article, the reclassification has been done ideally of previously described malignant and intermediate tumors, and this article gives it in detail. Moreover, this time there has been an involvement of the clinicians also in the pathological classification, and intermediate tumors have been accepted. This time again, morphology, besides morphology, that is immunohistochemistry and genetics, have been integrated widely into the classification. So the categories now, benign, intermediate, and malignant. Amongst them, benign and intermediate are seen across all 11 types, whereas the intermediate, locally aggressive, rarely metastasizing types are seen in adipocytic, fibroblastic, myofibroblastic, fibrohistiocytic tumor, vascular, smooth muscle, and tumors of uncertain differentiation. Remember, there are about 100 soft tissue tumors, more than 100 actually, and different subtypes in all these tumors. So how do we approach a slide? And that's what we are going to deal with today. Now, I'm going to go with the basics. That is, what were my problems when I was a resident, when I got a soft tissue tumor? And that's what we are going to see today. So how does one proceed? Do we straight away go to the high power? No, I have got a slide here now. Now, basically what you can see is it's moderately cellular, and then there's no necrosis in this power. So what is it and how is it that we proceed? Is it the same for excision and core, etc.? So now, one thing is that when we receive a core or open biopsy, first thing to decide is it representative? One. Second, is it a reactive lesion? After that, we decide whether it's benign or malignant. So assess the lesion under the scanner, then the low power, finally high power. Clinico-radiological correlation, absolutely essential in soft tissue tumors as in bone tumors. The differential diagnosis. So after you take out all the important and unimportant points, consider what are the possibilities and then rule them out one by one. So if you are unable to come to a conclusive diagnosis, we go in for ancillary testing. Now, ancillary testing doesn't just mean molecular testing or IHC alone. It also means special stains. So first you do with the special stains, and if you are able to come to close enough diagnosis, then you can go in for the IHC, which is required for these tumors. So molecular testing is also done these days. I'll be going into that a little bit later. So scanner and low power, what do you see? First, you decide whether this is benign, intermediate, or malignant, roughly. Not exactly, that can be done under high power. Then you decide about the cellularity. Is it moderately cellular, like this one? Yes. Then tumor normal junction. That is very important because you need to know whether there is an infiltrative margin or the margin is circumscribed. And another thing, if you get soft tissue tumors in skin, it's very, very important to check the normal because the tumor may be, supposing it's a dermatofibroma, the actually tumor may be very subtle in appearance. So in that case, it's very important to look at the normal and know what the normal looks like at that particular site. Then you go in for the pattern and architecture recognition, predominant cell type, presence of differentiation, is it poorly, moderately, or well differentiated? Then the background, whether there's chondroid, myxoid, or hyaline material in the background. Finally, the necrosis. Necrosis in these tumors is very important for grading. The next is high power. Here you confirm the cell type, like in this case. So now I know that it's showing your spindle cells and they're arranged side by side and almost parallel to each other. So this is a fascicle, and I may be thinking of either the smooth muscle tumor, like that. So confirm the cell type, then the differentiation. This looks almost like a fibroblast, so I may think, okay, most probably a fibroblastic differentiation. Then check for single cell necrosis. When you don't get wide or extensive amount of necrosis, apoptotic bodies and mitotic activity. Ancillary testing is then done after confirming all these. So you divide all your details, whichever you have seen, into important and unimportant, and remember that not just a single feature, but constellation of features are required for diagnosis. Then we move on to the cell morphology. That is the first of what it is. That is the basic structure or the basic unit of the tissue. So cell. So what is the cell shape? We have different cell shapes. You must be hearing, the postgraduates at least must be hearing of us telling you this is a spindle cell tumor, this is an epithelioid tumor, or a stellate cells are there, wiry cells are there, round cell tumor, pleomorphic, giant cell tumor. So what are these? The first one we'll deal with is the most common one, and that's the spindle. Now, this is a spindle which used to be used, earlier on, maybe in 1900s, etc., for weaving. So it has, sharp pointed ends at both sides, and in the middle, it's quite fusiform. That is a spindle. So which are the spindle type cells now? So it could be neural, like in this example, but here it's a little wiry. We'll be coming to that later. But spindle cells are there in neural. Then in a fibroblast, then in this is your strap cells, that is in rhabdomyosarcoma. You often get these kinds where the cells are elongated and the nucleus is at one end and dense eosinophilic cytoplasm is there. So these are strap cells, elongated. Strap cells are of different kinds. Remember that not just spindle, you can get even round or you can get even epithelioid. Then another one is this. This is actually a prototype of a spindle cell, and that's your smooth muscle cell. So smooth muscle cell is also spindle in shape. Next one is epithelioid. So whenever we say use the term epithelioid, we mean like epithelium. Oid is like. So like epithelium. Now like epithelium, actually there is quite a broad category. So you can have the like these. This is classical epithelioid, where you have little large and plump cells which are narrower at one end and broader at other. That's what we mean. Then you can get, epithelioid cells like you see in granuloma. Similar cells can also be found sometimes in tumors, for example, in epithelioid sarcoma. Then the next one is a different type of epithelioid, which is known as rhabdoid, where the nucleus is eccentric and there's moderate amount of eosinophilic cytoplasm. Rhabdoid, your morphology is associated with poor prognosis actually. Next is stellate. When we say stellate, we mean star-shaped. So look at this. So this cell has the cytoplasmic projections going out from all sides. That is what we mean by stellate. So don't expect exactly a star-shaped or a jellyfish-like pattern. What we mean is that it has cytoplasmic projections going about on all sides. This is actually an activated fibroblast or a myofibroblast. So here we can make out better still the central one. Now the wiry. Wiry, whenever I say, I think of two things. One is a fibroblast which is quite mature, like in this picture. This is actually a slide of fibromatosis. I'll be dealing with that later. And it's wavy as well as thin. Now, wavy, when we say fibroblast, the cytoplasm is bipolar and kind of, like stiff wires. Whereas if you look at the next one, this is also a fibroblast. You can make out the stiff wires in this. Whereas if you look at neural tumors, the wiry appearance is more like a wavy kind, more like a smoother waves like that. So there is a difference between the wiry appearance in neural tumors and the wiry appearance in fibrous tumors or fibroblastic tumors. Next is round cell. Now, whenever we say round cell, we mean the small round cells. So small round cells. So when do we say small round cells? That is when the cell size is something like a small lymphocyte up to 2 times a small lymphocyte you can go. That is a small round cell, small round cell. Next is pleomorphism. Now, pleomorphic cells, many people use this term very loosely, but at least what I have learned is that pleomorphism, you say when you can see anisocytosis and anisonucleosis both at low power as well as scanner, and you don't have to hunt for it. So when it's very obvious, then you call it pleomorphic areas. Last is giant cells. So giant cells are of different types, and the importance of knowing these giant cells is that some of these giant cells are associated with particular tumors. Like for example, this pictures that you see cytoplasm, eosinophilic cytoplasm in the center, and it's rimmed all around like a ring of dark nuclei, and around that what you're seeing is cytoplasmic vacuoles of lipids. So these are known as two-tone giant cells, and you see them in pleomorphic lipoma as well as benign fibrous histiocytoma. This is a florid giant cells. Actually, it doesn't look very large. It's slightly maybe 2 to 3 times larger than the adjoining cells, but the nuclei are all at the periphery and they are hyperchromatic with eosinophilic center. Looks like a flower. So florid giant cells. These florid giant cells are classically seen in neurofibroma. Then this is a case of actually MPNST. Then giant cell fibroblastoma as well as pleomorphic lipoma. So pleomorphic lipoma has both florid type and two-tone type of giant cells. Horseshoe or wreath type of cells, I don't have a picture of that. As the name suggests, it's the nuclei placed at the periphery in the shape of a U. So the center is having the cytoplasm. That's how a horseshoe or wreath-shaped cell will be, and that's seen classically in two conditions: alveolar rhabdomyosarcoma and clear cell sarcoma. Next is the osteoclastic giant cell. So this looks like an osteoclast. So how does an osteoclast differ from other giant cells? You see bland nuclei, vesicular nuclei without hyperchromasia, and plenty of them, and most of them are centered around the middle of the cell. That is typical of an osteoclast. So these are called as osteoclastic giant cell, and the prototype of this is tenosynovial giant cell tumor. So now cell type we move on to. So if we finish the cell shape, now we move on to the cell type. So cell type, the fibroblasts are elongated or oval. Now they have tapering ends, remember that. So bipolar cytoplasm is seen as you see here. You see bipolar cytoplasm all around, and this is wiry cytoplasm. Remember, the cytoplasm is wiry, like wiry wires on both sides of the nucleus, and the nucleus is wavy. Now, this is when in an older fibroblast. A younger fibroblast is smaller and has spindle-shaped nucleus like this. Now, the next one is smooth muscle. This is again another example of the same. That is a fibroblast. You also see an atypical fibroblast in this picture. Now, this is a smooth muscle. I told you already that it is a prototype of a spindle cell. Now, in fibroblasts, the cytoplasm was, like fibrils. Here, the cytoplasm has fibrils. So that's the difference between the two. Another thing is, look at the nucleus in this. The nucleus has, parallel edges and blunt ends. On both sides, they are blunted as the edges are very parallel. So this looks like a cigar. So cigar-shaped blunt-ended nuclei is typical. Most of the time, you also get cytoplasmic vacuoles. So this is your leiomyosarcoma and has quite a array of cytoplasmic vacuoles actually in most of the cells. Then next one are the neural ones. So we have one type of cell here which I recently got this case actually. So what you're seeing is a large cell with abundant eosinophilic granular cytoplasm. Here it looks quite amphiphilic. Usually it's eosinophilic, and the nucleus is vesicular, and this is a granular cell thought to be neural in origin. Now next is Schwann cells. So Schwann cells are cells which show this nuclei which are tapering at one end but blunt at the other. Remember, like almost like a thin triangle or a thin cone like that. So that will usually show buckling, that is, it's folded on itself, or it's comma shaped or hooked. So that's when you think of Schwann cells. Now, perineural cells, I couldn't get a picture of that, but perineural cells are thin thread-like. So you see pink, light pink threads with a central dot, and that is a nucleus, blue dot. So that is a perineural cell. Myofibroblast I've already shown you. So this has abundant amphiphilic cytoplasm and cytoplasmic processes all around. So stellate shape. So fusiform nucleus is what we see in this condition. Next, and the last one is the synovial sarcoma cell, that is sausage shaped and doesn't have much cytoplasm. They are small spindle cells actually, but remember that it is very, very uniform. Now, this is adipocytic differentiation. So here when we see, you see the center, you see a lot of large cells with single vacuole and the nucleus at the periphery. This is classical adipocyte, and you're seeing adipocytes of different shapes and sizes here. Now in between that, what you see is these cells. So what are these cells? Now these cells, if you notice, especially the one here, you're seeing indentation of this nuclear outline by these cytoplasmic vacuoles, and that is the lipoblast. So will lipoblast always be this big? No, you can get small lipoblast also, or in myxoid liposarcoma, you get small lipoblast as well as this spindle, signet ring cell lipoblast. Can you make out the signet ring cell lipoblast here? And small lipoblast. So these are seen only in your myxoid liposarcoma. Now, these kind of pleomorphic lipoblast is what we should look for whenever we suspect liposarcoma. Now, you can also get spindle cells, that's somewhere here. So that is a pre-adipocyte which you see. Now, lipoblast-like cells can sometimes be seen in other conditions, especially myxofibrosarcoma. So in that, these are known as your pseudolipoblast. So how different is a pseudolipoblast from a lipoblast? If you look at this cell here, you see two nuclei, but then you don't see indentation of the nuclear outline, and you're seeing pale blue cytoplasm similar to what is seen around it. That is like, you're getting mucin there. So there's plenty of mucin within the cytoplasm also. The last one here is a spindle cell lipoma. You'll get, along with these adipocytes, you may get some spindle cells, that is like this here, stromal cells also. Now we move on to pattern analysis. So we have done with the cell shape, then we are done with the cell type. Finally, we move on to the pattern analysis. So what's the most frequent pattern that we see? The most frequent pattern that we see is the fascicular pattern. Now, fascicular, initially I was, as a postgraduate, I kept wondering what is a fascicular pattern. Later on, I got to remember, or I rather read up, that this is just after fascicles. So where do we see fascicles? Remember the nerve fascicles, the smooth muscle, fibers together in fascicles. That is fascicle. Basically, it just means a bundle. That is cells arranged parallel to each other and streaming in the same direction. That is a fascicle. So where will you see them? You see them often, and mostly in spindle cell tumors. Please remember that. So you'll see them in neural tumors, smooth muscle tumors, and fibromatosis. So the malignant counterparts of those, like malignant peripheral nerve sheath tumor, leiomyosarcoma, fibrosarcoma, and synovial sarcoma. Now, the two important points to remember as far as MPNST is concerned and synovial sarcoma is concerned. MPNST, alternate hypo and hypercellular areas are there. In synovial sarcoma, the cells are uniform and the whole tumor looks very blue, or the section rather looks very blue. So now this is a fascicular pattern. So you see spindle cells going in fascicles here, all unidirectional. This is also a fascicular pattern. Actually, here getting wiry cytoplasm, so you suspect first a fibrous tumor. And in this fascicle, if you see, the cells are not touching each other, and there is this intermediate sized vessel with perivascular edema. That's classical for fibromatosis. Cells don't touch each other, intermediate sized cells, and then edema around that. And these are very, very long fascicles. Actually, they say that from one end of the section to the other, you can see the fibromatosis fascicles. Next pattern is the storiform pattern. This is a beautiful picture drawn here. I couldn't get better one actually. It's so nicely done here. So what does it show? It shows small fascicles and they're curving from a central point. So remember that. Short fascicles. Now in tumors, if you're very lucky, you may get this pattern exactly like this, but most of the time you get an overlap of this storiform pattern. Now this storiform pattern, the story is actually got from rush mat. That rush mat in Latin is known as story, S-T-O-R-E-Y. S-T-O-R, I think. Yeah. So the next one, which are the conditions we get the storiform pattern? So fibrohistiocytic tumors, then perineurioma, neurofibroma, and loose your fascicles can be seen in nodular fasciitis, fibromatosis, solitary fibrous tumor. Then you can see the same in dermatofibrosarcoma protuberans also. Malignant conditions also show them, and those are low-grade fibromyxoid sarcoma, dedifferentiated liposarcoma, and synovial sarcoma, and MPNST also. So this is a storiform pattern. So you may think, where exactly is that? Now you're seeing all these short fascicles. Over here, you see that radiating from the center. So in all directions, and they're not straight lines, they are slightly curved. So that is the storiform pattern. So here multiple storiform patterns are there, but they are overlapping. So here also there's one. Next condition is, it's beautiful to look at actually when you get a slide with a herringbone pattern. As the name suggests, it looks like the bone of a herring. So herring is a fish. So what do you see? You see crisscrossing of fibers like this. So what happens? Two long bundles crisscross each other. So you get multiple V's, and these V's are stacked on each other. So just remember it as stacking of V shape. So this is seen in very few conditions, mostly in dermatofibrosarcoma protuberans. It's classical. You can see it in fibrosarcoma also. Besides that, monophasic synovial sarcoma. Now, tissue culture pattern. So initially I kept wondering, what is this tissue culture? Later on I got to know this is nothing but when you grow fibroblasts in a culture media. So what happens there is you have a lot of ground substance in the background, and these fibroblasts are spindly and stellate, which just haphazardly arranged. So when there's a plenty of ground substance, you call it tissue culture pattern. So haphazard fibroblast arrangement is seen. You can see it mostly in all the fasciitis, so nodular as well as proliferative fasciitis. You can also note it in fibromatosis, low-grade fibromyxoid sarcoma, and synovial sarcoma. So this is your nodular fasciitis. You can see a haphazard arrangement of collagen and fibroblasts as well as inflammatory cells in a myxedematous background actually. It's not exactly blue, but it's pale blue. Then this is fibromatosis. Over here on top, you can see them streaming straight, parallel to each other, unidirectional. So there's a fascicle. Whereas here, look at this. When you see this, this is all, haphazardly arranged. It's not in one direction. So this is a tissue culture, your tissue culture pattern, and there is ground substance here. So remember one thing, and that is that fascicular herringbone storiform patterns are common to any of the types which has fibro in it. So fibroblastic, myofibroblastic, and your fibrohistiocytic tumors, whereas fascicular and storiform pattern, that is without the herringbone, is seen mostly in neural tumors. Fascicular pattern alone can be seen in your smooth muscle tumors. Then palisading, that is your fence of pales. So how did this name come? You see this beautiful fence here. So what do you see? You see these, slats of wood. These are known as pales. So these pales of wood which are parallel to each other but perpendicular to the ground. So on a line, if the cells stand like that parallel to each other, it looks like a fence. So you can't call it a fencing of cells. So instead, we call it palisading of cells. So palisading of cells is typical to your benign tumors of neural tumors, predominantly smooth muscle tumors. Sometimes you say, okay, it has that neurolemoma like leiomyoma, then palisaded intranodal myofibroblastoma, even spindle cell lipoma. Focally, it can be there. Malignant conditions, usually in malignant peripheral nerve sheath tumor, leiomyosarcoma, your gastrointestinal stromal tumors, synovial sarcoma, and desmoplastic small round cell tumor. Excuse me. Now, what is this? This is a Verrucke body in a neurolemoma. So, what do you see here? In a line, the cells are standing, the nuclei are all at the periphery on both sides, and the cytoplasm is in the center with the nuclear free zone. So, this is palisading. These two patterns are a little different. What do you see here? You see serpiginous nodules. Now, this is classically seen in your dedifferentiated liposarcoma, as well as it forms a plexus, Wait, first one, actually, I needed to show you the mosaic pattern, which is not there. I'm so sorry, the mosaic pattern hasn't come here. So mosaic pattern is actually nothing but, two different types of malignancies which are near each other, like the mosaic pattern of the flooring, that is seen in dedifferentiated liposarcoma. Sorry, the plexiform pattern is seen in your neural tumors. It could be neurofibroma, it could be neurolemoma. And why is it called plexiform? Because the serpiginous nodules are together in, and you cut them. How does it look? Supposing you say brachial plexus, if you, branching out, the nerve fibers are branching out, and then you cut that section. How does it look? Some are longitudinal, some are cut section, and that's how this looks. All are closely packed. That is your plexiform pattern. It's also seen in neurothecoma and plexiform fibrohistiocytic tumors. Now this, you'll be wondering, what has Madam done here? Why has she kept a slide of lung parenchyma? So these are all alveoli. How are these alveoli? Really irregular. Excuse me. So this irregular alveolar pattern is very typical in alveolar rhabdomyosarcoma. Excuse me. It's classical of alveolar rhabdomyosarcoma. Then when the alveoli are very regular, you get that in alveolar soft part sarcoma like this. Now, how does this happen? Why do the cells stick to each other? To each other only at the periphery. In the center, they're discohesive. Pseudoalveolar pattern is also noted in Ewing sarcoma. So here again, the cells are more discohesive, and this is irregular, but not a true alveolar pattern. Sclerosing epithelioid fibrosarcoma could also show it. Now this is a nice, beautiful filigree pattern, very delicate design. So this kind of pattern you can get in Ewing sarcoma and peanut. Rosettes are seen, both rosettes and pseudo-rosettes in the neural tumors, neuroblastoma, schwannoma, peanuts, as well as in low-grade fibromyxoid sarcoma. And DSRCT here, when it's seen with pseudopapillae. So this is a filigree pattern. And here you're getting a true rosette. And over here, you're seeing a pseudo rosette with neuropile in it. Plexiform, palisading, and rosettes are common to neural tumors. Okay. So this is the mosaic pattern which I had mentioned earlier. I think I had forgotten to put it there anyway. So next one is the nodular or lobular patterns. Mosaic pattern is seen in, as I told you, dedifferentiated your liposarcoma. Then lobular pattern is seen when you get, nests of cells separated by fibrous septa and surrounded by it. So when you get large nests, you call it lobules or nodules. So this is seen classically in lipoma, lipoblastoma, malignant, that is your liposarcoma, then clear cell sarcoma, epithelioid sarcoma, extraskeletal myxoid chondrosarcoma, as well as myxofibrosarcoma. Now, what is this pattern? Now, this is typical of only one condition, and that is myxoid liposarcoma. So, when you get this type of pattern, please remember to look for other areas and all that other vasculature, etc., which I'll be describing a little later, and put it together and think of myxoid liposarcoma. These are microcystic spaces which are far apart and filled with mucin. So, this looks like pulmonary edema. This is another picture of the same. Now, whenever the cells are placed one behind each other and in a line, it's called as cords. So, linear arrangement of tumor cells is called as cord-like pattern. So, benign condition is chondroid lipoma, and malignant again chondroid, that is myxoid chondrosarcoma. You can also see it in some vascular tumors like epithelioid hemangioendothelioma, epithelioid MPNST, that is malignant peripheral nerve sheath tumor, round cell liposarcoma. Trabeculae are nothing but two cords of cells placed very nearby or more than two. If it's just restricted to two, you call it a microtrabeculae. If it's more than two, then you call it macrotrabeculae. So this is typically seen in ossifying fibromyxoid tumor. Two patterns here. So the top one is you're seeing glands. Now, how can you get glands in sarcoma? It can be there. So one is biphasic synovial sarcoma, and the other one is malignant peripheral nerve sheath tumor with heterologous elements. These are two conditions where you can see glandular patterns. Then reticular pattern. What is reticular pattern? Now, in this picture, you see this lace-like design wherein, small different microcystic spaces are surrounded by either cells. I mean, here it's of course thread work, but it's either cells or else the cytoplasmic processes. So when you get like this or like a net-like pattern, you call it reticular pattern. It's seen in extraskeletal myxoid chondrosarcoma, myoepithelioma, and your neural tumor variants, that is perineurioma and schwannoma. You call it reticular variant of perineurioma or reticular variant of schwannoma, which I have here, and a better picture here. You can make out the microcystic spaces, plenty of microcystic spaces here. So this is known as reticular pattern. Now, other patterns are there. So there is this patternless pattern. Initially, I was like, how can you call it patternless pattern? How can a pattern be patternless? So basically, what they mean to say is they want to differentiate it from the tissue culture pattern. Again, in this pattern also, there is haphazard arrangement of cells, but with a difference, there's not much of that amorphous ground substance which we saw earlier. So this is seen classically in solitary fibrous tumor. Pseudovascular pattern is the last one amongst the your cellular patterns that I'll be showing. And this is where you get spaces which look like blood vessels, but then they are not blood vessels. So this pattern can be seen with giant cells or without giant cells. With giant cells, it's seen in two conditions. One is giant cell angiofibroma and the second one is giant cell fibroblastoma. This here which you see is a case which we got, that is giant cell fibroblastoma, that will show certain your fibrosarcoma like areas in, that is with spindle cells, storiform pattern as well as herringbone like pattern, and then you'll get these giant cells, quite a few of them, but lining these spaces. You'll also get hyaline material. The next one is what we see here. So I think everybody has guessed it right. Yes, the staghorn pattern. Earlier it was thought to be classical of hemangiopericytoma. So it's known as hemangiopericytic pattern. It's either called the staghorn pattern or antlers. So it's seen in benign conditions like solitary fibrous tumor, myopericytoma, malignant synovial sarcoma. Just remember one thing, whichever pattern is there in solitary fibrous tumor is also there in synovial sarcoma. Then mesenchymal chondrosarcoma, leiomyosarcoma, and malignant peripheral nerve sheath tumor. So this is just CD34, which I did. I found it nice and I put it across, and this is one of the pattern. I mean, the hemangiopericytic pattern in one of the tumors. Pericytic pattern is a little different. I couldn't get pictures of that, but here the cells are all surrounding the blood vessels, classically seen in myopericytoma, synovial sarcoma, and solitary fibrous tumor. Now, in MPNST or malignant peripheral nerve sheath tumor, what happens is the cells surround, there is vascular proliferation like you get in glioblastoma multiforme, and there is also the cells surrounding the vessels and almost herniating inside. So that kind of pattern is typical for MPNST. Other vascular patterns are there like this. I call them crow's feet pattern actually. And when these, branch out, you get this arborizing or plexiform arborizing vasculature, very, very classical for myxoid liposarcoma. So two things we saw which were classical for myxoid liposarcoma. One is the pulmonary edema pattern and the other is the vasculature. So don't forget this when we deal with myxoid tumors. Other conditions which show this, especially in the myxoid portion of low-grade fibromyxoid sarcoma, myxofibrosarcoma, and nodular fasciitis. But in myxofibrosarcoma, how do you differentiate? These two are close differentials. Now, one of the ways we differentiate this is that the vessels here in myxoid liposarcoma are very thin, whereas in myxofibrosarcoma, they are thick vessels in plexiform arborizing pattern. We also get another pattern in myxofibrosarcoma where they form, the vessels form lines or they are little curved like this. So that is curvy linear pattern of vasculature seen in myxofibrosarcoma. Next is stroma. So stroma is of different kinds. You get your myxoid stroma where it is a loose, pale, slightly basophilic, mucin-like. Then you have chondroid where it's a little thicker, it's not exactly fibrillary and it's quite thicker and it's basophilic, nicely basophilic material. Get it in all chondroid tumors. Hyaline material, this is extracellular glassy and eosinophilic. Now, hyaline material and early osteoid look almost similar. Early osteoid is PAS negative and hyaline material is PAS positive, brilliantly PAS positive actually. Please remember that. So whenever you have a doubt between these two, you can always do the special stain PAS. Seen in solitary fibrous tumor and schwannoma. Now in solitary fibrous tumor, quite a lot of it is seen actually, this hyaline material. In schwannoma, it's classically perivascular. So this is hyaline material, extracellular hyaline material. Now, when you look at this, it looks as if it's in the same plane. Now, this is very important. You see your eosinophilic material, which is glassy, and it's quite homogeneous, but in the same plane as this. Whereas, if you look at this, yeah, over here, what happens is that your it's quite thick actually, very thick, and it looks as if it's in two different planes. This is, three-dimensional and this is two-dimensional, that kind of feeling. So this is early osteoid and this is late osteoid. So eosinophilic, pale, thick and opaque is osteoid. Now the fibrous one, you get your thick collagen in spindle cell lipoma. Now solitary fibrous tumor also shows and neurofibroma. In solitary fibrous tumor, it's almost keloid-like and it separates out those into cleft-like spaces. The cells will be separated out. Neurofibroma, it's classically perivascular. And remember one more thing, very, very typical, you get collagen as shredded carrots in neurofibroma. Haphazardly arranged cells with shredded carrot collagen is classical for neurofibroma. Then thin collagen is seen in your liposarcoma, that is sclerosing type, and synovial sarcoma. In synovial sarcoma, it classically surrounds each cell. So this is thick collagen here, which you can make out. The first case was spindle cell lipoma, and now this one is your solitary fibrous tumor. Now sclerotic is, how do you differentiate this just collagen like that from sclerotic? And another one is desmoplastic. Now, sclerotic is when you get this very thick fibers and it's fibrillar. Earlier one, that is your hyaline material and osteoid, it's non-fibrillar. In sclerotic, it's densely eosinophilic and fiber-like. These are seen in all sclerosing sarcomas. Before I move on to the next, let me tell a little bit about what is desmoplasia. Desmoplasia, you get fibroblastic response, abundant collagen, and it's cell poor, and inflammation is less in that area. Now this myxoid tumors, so you have, depends on the cellularity, it's divided. So you have scant cellularity wherein you can get in your what is that, myxoma, as well as your aggressive angiomyxoma. So these two can be differentiated based on, one is your vessels. Aggressive angiomyxoma, as the name suggests, it has vessels, and there is hyaline material in the stroma, as well as there they have your smooth muscle fibers, yes. Now, myxoid, when you look at moderately cellular smears, so what do you see in, moderately cellular sections, then in that case, you look at the cell type. Is it spindle cell? Is it round? Or is it epithelial? So you have neural conditions and fibrotic. So, neural, you have schwannoma, as well as your perineurioma also you can get. Then in these conditions, how do you differentiate? I told you perineurioma, thread-like cells. In schwannoma, you get antennae A and antennae B areas, hypercellular antennae A areas with verruca bodies, and hypocellular with that perivascular hyalinization. When it's fibrotic, there are two conditions, nodular fasciitis and low-grade fibromyxoid sarcoma. Low-grade fibromyxoid sarcoma, as the name suggests, there is fibrous areas and there is myxoid areas. And fibrous areas has hyaline areas also. And in the myxoid areas, when you see, it's very uniform. It looks low-grade. In nodular fasciitis, of course, the pattern you should look for, that haphazard arrangement with the ground substance. So that will help you, and a lot of inflammation is there in nodular fasciitis. Next one is a round cell type, myxoid liposarcoma, myxoid chondrosarcoma. Now, in these two, the cells are different, one, but most important of all is myxoid liposarcoma. I already told you, pulmonary edema pattern and your arborizing vasculature, plexiform arborizing vasculature. Myxoid chondrosarcoma is hypovascular. Now, when you get an epithelioid, sorry about the spelling mistake here. When you get epithelioid cells, think of a chordoma and look for the physaliferous cells. Just a minute. Yeah, hypercellular, again, when you see, look at whether it's epithelioid and spindle. Epithelioid is myxoinflammatory fibrosarcoma. Spindle shaped is myxofibrosarcoma. Now, both of them will show pseudolipoblast. So, how do you differentiate these two? Myxoinflammatory fibrosarcoma, as is mentioned, there's a lot of inflammation, and that inflammation is eosinophil predominant. You'll get virocyte-like cells, that is Reed-Sternberg-like cells, and there is emperipolysis in that. That's how you will distinguish this. In myxofibrosarcoma, a lot of pleomorphism is there, then your curvilinear vessels, plexiform vessels also. So this way we can distinguish these two. So we have finished with that. Now, based on all these things, let's look at the classification based on cell morphology. So first is spindle cell tumors. Now these are the most commonly seen tumors across all categories, that is fibroblastic, myofibroblastic, but predominantly among these. Fibrohistocytic, vascular, less often. More often it is usually epithelioid, then smooth muscle, gastrointestinal stromal tumors, and peripheral nerve sheath tumor. This I have already explained to you. This is fibromatosis, cells which are not touching each other, blood vessels intermediate sized with perivascular edema, a lot of collagen in between, wiry cells. Now the next one, what do you see? You see the storiform pattern, which is, overlapping. The storiform pattern is overlapping. You see spindle cells, you even see fascicles, you see collagen, then you see these histocytes here. So combination of fibrous and histocytic elements, it's a fibrohistocytic tumor. Now here you're seeing the prototype spindle cells with fibril within the cytoplasm, and you are having a cigar-shaped nucleus. So this is smooth muscle tumor. Now, GIST or gastrointestinal stromal tumors look exactly alike from that. But one thing is that the nucleus is a little more pointed as compared to the smooth muscle tumors. Last one is the peripheral nerve sheath tumor. This here actually is an ancient schwannoma which I have taken out. Now, in peripheral nerve sheath tumor, the nuclei in these have pointed one end and the other end is blunted, and it can be buckling, hooking, like here, see. This is a comma here, nice comma is there, so that way you can differentiate. Now here it's in fascicles. Now round cell tumors, so in children there's a different one, and in your adults there are different ones. Now desmoplastic small round cell tumor, all these are malignant, so DERN. Desmoplastic small round cell tumor, where you get a nest of cells with the peripheral palisading, then pseudopapillae as well as your rosettes you can get. Now, and around that there is desmoplasia, separating the mass of cells. Then Ewing sarcoma, peanut, which I have already shown you. Rhabdomyosarcoma could be embryonal or alveolar, and neuroblastoma. Neuroblastoma, of course, you can get the neurofibrillary matrix in the background as well as rosettes, pseudo-rosettes. In embryonal, you get the cambium layer, which is the hypercellular layer, the periphery, and then you get alternate actually of hypocellular areas also. Then in alveolar, I showed you irregular alveoli lined at the periphery with smaller cells, and in the center it will be discohesive cells. In adults, you get plenty of them, but the most predominant one are the tenosynovial giant cell tumor, glomus tumor. Malignant, you have round cells, liposarcoma, the chondrosarcomas, the mesenchymal, as well as myxoid, and small cell osteosarcoma. Small cell osteosarcoma, you can distinguish with the help of the osteoid which is present, and mesenchymal chondrosarcoma, you get well differentiated chondrosarcoma areas and these round cell areas. That's how you make out. Myxoid liposarcoma, your chondrosarcoma, I have already told you, linear cords of cells will be there, hypovascular tumor, and a myxoid background. Round cell liposarcoma will have the myxoid areas also, which has that myxoid liposarcoma pattern. So let's look at the slides now. So this is Ewing sarcoma, and it has large nests of cells with a kind of filigree pattern, and there are small rosettes here. Then next another nice true rosette here. And this is your tenosynovial giant cell tumor, which has both your round cells as well as hemosignal-laden macrophages, then histiocytes, and multinucleated giant cells, osteoclastic. Epithelioid tumors, most of the time it's seen in vascular lesions, that is hemangioma, you have hemangioendothelioma. Epithelioid hemangioendothelioma shows large amount of eosinophilic material, fibrinoid, maybe it may be fibrinoid necrosis. Around that you get this epithelioid cells and spinal cells. Angiosarcoma has cleft-like spaces lined by these epithelioid cells. Now in all the vascular tumors, remember to look for intracytoplasmic lumen. That is, there's an intracytoplasmic vacuole with RBCs, and that is intracytoplasmic lumen. Now neurotumors also you can get, that we have already seen. Then others are alveolar soft part sarcoma. I showed you that is an alveolar soft part sarcoma has alveoli which are very organoid and larger cells with eosinophilic cytoplasm, as well as your vesicular nucleus and prominent nucleoli. Epithelioid sarcoma, especially the proximal type, will show characteristically these kind of cells along with rhabdoid cells. A lot of discohesiveness will be there. Then malignant rhabdoid tumor, as the name suggests, very rhabdoid cells will be seen with plenty of discohesiveness. Sclerosing epithelioid fibrosarcoma, you can get the abundant amount of sclerosis in that with collagen rosettes, etc. Then gastrointestinal stromal tumor, that is where you get the epithelioid type, usually seen in STH mutated one. Then pleomorphic tumors. Pleomorphic tumors you can get across all types in the malignant category, and intermediate is atypical fibroxanthoma. Benign, here you get plenty of atypical cells in between and foamy macrophages as well as histiocytes. Then benign condition is pleomorphic lipoma, ancient schwannoma as well as neurofibroma, and pleomorphic hyalinizing angiectatic tumor. Pleomorphic lipoma, you will not get much of mitosis and no necrosis will be there, but pleomorphic cells and the Teuton giant cells, floret type of giant cells, can even get lipoblasts in that. Ancient schwannoma, I had already shown you one case. Most of the areas will show the typical antony A and B areas, or in neurofibroma the shredded carrot, but along with that you will get your occasional bizarre cell or atypical cell, and so pleomorphism will be there. Pleomorphic hyalinizing angiectatic tumor, we had a case, it shows some fibrolipomatous areas, and then along with that you get the spindle cells which are atypical. You can get giant cells also, and blood vessels with a lot of hyaline deposits in that and dilated. Ectasia means dilation. So pleomorphic hyalinizing angiectatic tumor. So peculiar features of all these tumors, what exactly is so different in a particular tumor that you can make out that tumor as soon as you see it. So low-grade fibromyxoid sarcoma shows how alternating hyaline collagenous and myxoid areas and giant collagen rosettes. Intramuscular myxoma shows macro circumscription but micro-infiltration. Nodular fasciitis, remember the rule of 3, third decade, 3 months and less than or equal to 3 centimeters. Calcification, actually very classical in synovial sarcoma, can be seen in chondroid lipoma also, even ossification. Fibromatosis, I told you already, cells are separated by collagen, they don't touch each other at all, and you get long, extra long fascicles, across the entire section you can make out. Then vascular tumors, benign, have sharp margin, lobules of mixed size of vessels, whereas in angiosarcoma, irregular margins, and the cells will be dissecting the tissue planes. Now, sarcomas favoring retroperitoneum are usually the liposarcomas, the well-differentiated and the dedifferentiated, and fibrosarcoma. Painful lesions are the angles, that is angiomyoma, the neural tumors, glomus tumors, leiomyoma cutis, epithelioid fibrosarcoma, the sclerosing type, and the synovial sarcomas. Now, what is the role of ancillary tests, special stains? So, what is the role of these special stains in soft tissue tumors? It's very, very important, especially in the spindle cell tumor. I always do special stains. So, Mason trichrome is very important in distinguishing the two. So, over here you can see this is actually your gonadal stromal tumor with myoid differentiation, a case which we had. So, in that, what is this? This is all showing green. So, this is fibrous, and this, what you see, are the myofibrils within the smooth muscle fibers that is stained red. Next, reticulin. Reticulin surrounds individual cells in sarcomas. So, this is again another case of that Mason trichrome. Now, this is one case which we had, which I'll help in explaining, reticulin, importance of reticulin. So, surrounds individual cells in sarcomas. In MPNST, it runs parallel to the spindle cells, and in certain cases, it helps to distinguish, because like something like Ewing sarcoma and this case which I am showing you now, it is usually reticulin poor. Now, in this case, this I had called it as, it was a paraspinal mass, so we had called it as neurolemoma, but the clinical differential was an ependymoma. So, your tancytic ependymoma is a close differential for schwannoma. So, for that reason, we did reticulin in this. So, you can make out all the coma-shaped nuclei. Now, here you can see that the reticulin surrounds each cell, whereas in your tancytic ependymoma, it surrounds group of cells. So, it's very helpful. PTH can also be used for skeletal muscle cell striations. Now, the last one is periodic acid shift and periodic acid shift with diastase. So, this helps in when you get the alveolar pattern. Is it an alveolar soft part sarcoma you're dealing with, or is it a rhabdomyosarcoma? Now, in alveolar soft part sarcoma, it is diastase resistant, whereas rhabdomyosarcoma is diastase sensitive, meaning the pink disappears after diastase. So, this granules you can see, or sometimes you can even see crystals in alveolar soft part sarcoma. Ewing sarcoma also, it's very efficient in finding out Ewing sarcoma, detecting in the round cell tumors. Nice and brilliant positivity of cytoplasm with PAS you get, and it's PAS diastase sensitive in Ewing sarcoma. Next one is immunohistochemistry. Very important, because it helps in distinguishing so many tumors. Now, before the advent of immunohistochemistry, it used to be a lot more difficult. Now, immunohistochemistry can be diagnostic or prognostic or theranostic. By theranostic, we mean that with the advent of all this targeted therapy, so it helps in telling whether the targeted therapy would be useful in a particular tumor or not. That's why we use the term theranostic. Even molecular studies, that is your cytogenetics as well as other molecular studies, are also useful in all these three. So the staining, remember to check whether it's cytoplasmic, membranous or nuclear in the tumor, then check which are the normal cells which stain with these. Then also check normally how does it stain, and in that tumor how is it supposed to stain. That is very important. Supposing you're expecting membranous staining and it's cytoplasmic, then it's not positive. Another thing is, if you're expecting a nuclear stain and it's cytoplasmic, again it's not positive. Now, muscle markers are Desmin. So, Desmin is positive in both smooth and skeletal muscle. So, why do we have to do the other markers? Because we need to differentiate them. The treatment wise, it's different. So, smooth muscle is SMA and H-cal Desmon. Now, remember one very, very important thing, that is tumors arising from vascular smooth muscle are negative for Desmin, whereas all other smooth muscle tumors are positive for Desmin. So SMA and Desmin positive is a smooth muscle tumor, but SMA and Desmin negative, SMA positive, Desmin negative, kindly do H-cal-Desmon, because it could be a vascular smooth muscle tumor, in which case it will be positive for your H-cal-Desmon. Myofibroblasts show a typical tram track SMA positivity, but they are negative for H-cal-Desmon. Glomus tumors are positive for both. Skeletal muscle, it's myogenin and myod1. This is very important because alveolar rhabdomyosarcoma is your excuse me, myogenin is more than myod1, whereas in embryonal rhabdomyosarcoma, myod1 is more than or equal to myogenin. Sorry. Yeah, just as we know, that is gastrointestinal stromal tumor. It's beautifully taken here. So this is CD117, then SMA, CD34, S100, and DOG1. This is discovered on GIST. So of course, PDGFRA in some of the cases. Now, whatever is positive for CD117 will be negative for PDGFR. They are mutually exclusive. Please remember that. Now, SDH mutation can be there in either of them. And this is very important because it may not respond to therapy. Vascular markers are CD31, CD34, these are important. Then FLI1 can also be used, ERG is also used, the other two are not often used. So sometimes these your blood vessels can be positive for CKEMA, CKIT also. Peripheral nerve sheath tumors, this is ascended positivity in schwannoma. 100% positive. So then you may ask, what about neurofibroma? Isn't that positive too? It's a benign tumor. Yes, it is positive, but it shows not as much as your schwannoma, because in between there may be fibroblasts. So those fibroblasts will not take up S100, only the neural cells will. So it's not as completely or diffusely positive and strongly positive as schwannoma. Now this is very important, especially in, wait just a minute, sorry. Okay, this is very important because in MPNST, it's variable, that is one. And another thing is ancient schwannoma or ancient neurofibroma, we need to know whether, it's a malignant condition or not. You do the your S100. If it's 100% positive, then definitely it's not malignant. CD34, it's positive in neurofibroma. In MPNST, this becomes negative. Very, very important. Another aspect is the pattern. In neurofibroma, you don't get fascicular, you don't get a fascicular pattern too much. Whereas in MPNST, when this neurofibroma becomes malignant, suddenly a fascicular pattern will appear. So remember that. And the CD34 negativity. Then MPNST, there is another marker now, that is H3K27ME3. So this marker is lost in MPNST. Other neural markers are, of course, SOX10, which is done more often now. Perineurioma is Claudin, GLUT1, EMA, and CD34. So this is one of the tumors which is EMA positive and CD34 positive. And tumors with specific markers. So Ewing sarcoma. Now, Ewing sarcoma, I always remember it this way. Ewing, so FLI1. Remember that. E wings is fly 1. The other one is NKX 2.2. This is positive in this. It's also positive in other conditions. Then TFE3 is there, which is positive in alveolar soft part sarcoma. Then MUC4 is very, very important for low-grade fibromyxoid sarcoma, sclerosing epithelioid sarcoma, and ossifying fibromyxoid tumors. Beta-catenin is most often it is actually it's classical for fibromatosis, but then remember that other tumors can also show like synovial sarcoma and SFT, but it's to a lesser extent. So if it's diffusely and strongly positive, think first of fibromatosis before thinking of other conditions. And TLE1 is seen in synovial sarcoma, but TLE1 can be positive in to a lesser extent in SFT. That's why when we have this differential, we do TLE1 and we do STAT6 also. The STAT6 is negative in synovial sarcoma. CD56 neuroblastoma classically. Now, this is another one which I like because desmoplastic small round cell tumor shows dot-like positivity for desmin. So DDD. Desmoplastic small round cell tumor shows dot-like positivity for desmin. Besides that, there is WT1 positivity. Now, WT1 in Wilms tumor, it usually shows cytoplasmic positivity, whereas in this condition, it is nuclear positive. Then, of course, DOG1 for GIST, then STAT6 in SFT, and it's also seen in dedifferentiated liposarcoma, but not to the same extent as in SFT, that is solitary fibrous tumor. So tumors with no specific markers are fibrosarcoma, myxofibrosarcoma, myxoid round cell liposarcoma, and pleomorphic liposarcoma. Of this myxofibrosarcoma, you cannot, there's no way that it could be found out even by other molecular methods, because they haven't found any specific molecular aberration which is constantly there in all myxofibrosarcoma tumors. The other three at least have some. Now, this particular one you have to make out only on histopathology and when all markers are negative. Now, Vimentin negative, usually Vimentin, we know that all mesenchymal tumors are positive, and some epithelial, that is your carcinomas, when they undergo your MET transition, that's positive. But negative Vimentin is seen in two soft tissue tumors, that is alveolar soft part sarcoma and PCOMAs. Now, why is it important to distinguish synovial sarcoma from solitary fibrous tumor? One is both have similar histomorphology, common IHC like CD99, BCL2, EMA, and TLE1. I told you synovial sarcoma, it's more, EMA is also more in synovial. So to differentiate, we do CD34 and STAT6. Both are positive only in solitary fibrous tumor. Now, synovial sarcoma, you can also do molecular markers, that is SYT. Now it is known as, I think, SS18, along with SSX1 and SSX2 combination. Then importance, synovial sarcoma is chemosensitive, whereas the other one is not. Now, pattern-based approach to immunohistochemistry. So you divide it into your IHC markers required for small round cell tumors, those required for spindle cell tumors, for epithelioid tumors, and for pleomorphic tumors, because then it becomes much easier than running a huge panel. So you have all these markers. Just a second. All these markers. So Ewing sarcoma, alveolar rhabdomyosarcoma, poorly differentiated synovial sarcoma, DSRCT, and lymphoma form the small round cell tumors. So in the small round cell tumors, first you do cytokeratin, LCA, CD99, and desmin. LCA positive in lymphoma only, so it's ruled out in the beginning itself. Cytokeratin may be positive in Ewing's and alveolar, but it's definitely positive in synovial and DSRCT, whereas CD99 is positive in Ewing sarcoma along with maybe synaptophysin, and alveolar rhabdomyosarcoma, of course, desmin will be positive, and these may or may not be positive. Poorly different synovial, CD99, TLE1 will help. Desmoplastic small round cell tumor, I already told you, very nuclear dot of desmin. And remember this one, CD99 is normally membrane positive, whereas here it is cytoplasmic positivity. Next is spindle cell tumors. So you have the just a second. You have the synovial sarcoma, the malignant peripheral nerve sheath tumor, leiomyosarcoma, rhabdomyosarcoma, angiosarcoma, the GIST, myxofibrosarcoma, solitary fibrous tumor, and the spindle cell melanoma. So you do a CK, S100E, SMA, and CD99. Now EMA, desmin, myoglobin, etc. will be done in the later stage. CD34, sorry, then CD99, CD117. Now synovial sarcoma is always positive for cytokeratin, I've already mentioned, and EMA. It could be for S100, CD99, most of the times it's positive. So then you can go in for the other markers. Then MP-NST is S100 positive, but not diffusely and not diffuse and strong, but it could show patchy positivity. Then you can go in for other markers once you see that. Then leiomyosarcoma is SMA and desmin positive. These may be positive. Rhabdomyosarcoma is desmin and myoglobin. Angiosarcoma, remember I told you about CD34 positivity in vascular tumors. GIST is of course CD117 and CD34. Myxofibrosarcoma, as you see, is negative for all. Solitary fibrous tumor, it's CD34 positive, CD99 positive, whereas the others are negative. So with the help of this, you can distinguish these tumors. The next one is the epithelioid tumors. Again, you do cytokeratin, LCA, CD34, desmin and SMA, or desmin or SMA in the first shot for differentiating poorly differentiated carcinoma, large cell lymphoma, epithelioid angiosarcoma, epithelioid sarcoma, epithelioid monophasic synovial sarcoma, leiomyosarcoma, clear cell sarcoma, GIST, and alveolar soft part sarcoma. This is positive only for 1 minute. This is, sorry. Okay, so poorly differentiated carcinoma is cytokeratin and EMA positive. Then large cell lymphoma is of course LCA positive and others all are negative, so you can rule it out. Then your epithelioid angiosarcoma is CD34 positive here. Epithelioid sarcoma, CK and EMA definitely positive, so also synovial sarcoma. How do you differentiate these two? Epithelioid synovial sarcoma, remember it's always negative for CD34. Then you have epithelioid leiomyosarcoma, desmin and SMA positive. Then clear cell sarcoma. This again is your positive for S100. Then epithelioid GIST is positive for CD34 as well as CD117. Alveolar soft part sarcoma is definitely positive for desmin. Then sorry for the mistake here. Just a second. Yeah, then pleomorphic tumors. So pleomorphic tumors, you do cytokeratin, SMA and S100 in the first panel. Then later on you can add the others, desmin, myogenin, CD31, etc. So melanoma may be positive for cytokeratin, but it's definitely positive for S100. Then you have angiosarcoma, which is positive for CD31. Then pleomorphic liposarcoma, focal positivity for S100 is noted, but not diffuse positivity. Remember that. Leiomyosarcoma may be positive for cytokeratin, but definitely positive for SMA and desmin. Pleomorphic rhabdomyosarcoma, desmin and myogenin. MP-NST is definitely positive, but focally for your S100. So next is grading. We are coming towards the end of the session now. So grading is according to FNC LCC grading. I won't be going into too much of detail. So remember that it is mitosis, necrosis and differentiation. So remember I asked you to look for necrosis. So this is the reason we look for necrosis. We have to quantify the necrosis. We have to see whether the differentiation is there and quantify the mitosis. Then a total score is given. So it depends on whether it is, it's like after adding up you get 2 to 8, then it is divided into 3 scores or 3 grades. So tumor differentiation, score 1, it resembles exactly the mesenchymal tissue. Score 3, it doesn't. That is undifferentiated or embryonal. Score 2 is in between. That is, you can make out the histologic type, but it resembles to some extent only, not as much as score 1. Mitotic count, less 0 to 9, 10 to 19, and more than 20 per 10 hyper fields. Next is your histology grade and tumor necrosis. Necrosis, no necrosis. Score 2 and 3 is whether it is more than, less than or equal to 50% or more than 50% necrosis seen. Then you grade it. Grade 1 is total score 2 to 3. Grade 2, score of 4 to 5. Grade 3 is 6, 7, 8. Now, what they have said is this: while treating, grade 2 and grade 3, they take as higher grade ones. Okay. Then these differentiation scores are not done for all tumors because they are not useful for certain ones, like your angiosarcoma, then your liposarcoma, dedifferentiated round cell or myxoid type, myxoid chondrosarcoma, alveolar soft part sarcoma, epithelioid sarcoma, clear cell sarcoma, rhabdomyosarcoma, alveolar, that is the alveolar and embryonal type. Then MPNST, actually there is a varied opinion on that. Some say it's useful, some say it's not. So studies are going on about that. Okay, so now we come to molecular diagnosis. Should we or shouldn't we do molecular diagnosis, and what exactly is it? We need to do it because again, it's for sometimes it's for diagnosis, and sometimes it's for prognosis. Like I mean, it can be like in alveolar rhabdomyosarcoma. What they say is if these two, if FOXO1A is involved with PAX3 or PAX7, then it's got bad prognosis and it's not the treatment is not as effective. Then in Ewing sarcoma group, you need to differentiate from the others, which are similar to Ewing sarcoma morphologically, but then treatment wise it's different, and they are not as chemosensitive as Ewing sarcoma. Then in alveolar soft part sarcoma, you need to confirm it. Then another important one is lipoma versus well-differentiated liposarcoma. So here HMGA2 is positive only is positive in lipoma, whereas liposarcoma is positive for HMGA2 and MDM2. So lipoma is negative for MDM2. Then we have the others here. Synovial sarcoma also require confirmation with your SYT is now known as SS18 with SSX1 and X2 combination. So what's the protocol for reporting? You have done everything. You have done cell typing, you check the shape, then you check the pattern, then you have done your special stains also. You have divided them as per the morphology. Then you have divided them as per the immunohistochemistry. You've done first panel, then you have done the second panel. You come to a conclusive diagnosis. Now you've even given for molecular testings. How do you report? Now follow the protocols. There are different data sets available, like your College of American Pathologists or Royal College of Pathologists. Both UK is different and Australia is slightly different. Then, but in all these things, one thing is common is the TNM staging. So TNM staging is 1 to 4, and it's based on the TNM classification. So we put one prefix P here, that means pathological TNM classification. So now this T category differs and it's location based. In superficial trunk, that is, it includes even the sarcomatous component occurring in breast as well as phyllodes, and extremities are together. Retroperitoneum is one, and in this included is the sarcomas exclusively arising in the peritoneum. Then head and neck includes everything from the your infratemporal region right up to cervical esophagus, including the salivary glands, the thyroid, the parathyroid, etc. Viscera, thoracic, and abdominal. Now, excluded from this classification are Kaposi sarcoma, infantile fibrosarcoma, then your intermediate grade tumors, especially the locally aggressive ones. Then in head and neck, besides these, angiosarcoma, rhabdomyosarcoma, both embryonal and alveolar, dermatofibrosarcoma, protuberance is also excluded. Then GIST, there is a separate TNM. And as per WHO, head and neck tumors as well as viscera should not be staged. So we've come to the concluding part actually. So before I sign out, let's remember to beware or be aware of diagnostic difficulties. So if it's looking benign, please rule out a reactive lesion first. And secondly, I told you, like in MPNST, you get hypocellular and hypercellular areas. So if supposing the biopsy has been done from the hypocellular areas, so then in that case, be aware that hypercellular areas may also be there in the tumor, so the excision specimen may be different. Then looking malignant, first rule out a carcinoma or a lymphoma, especially the epithelioid and the round cell ones, rule out a lymphoma. Spinal cell ones, there is a carcinosarcoma or sarcomatoid carcinoma, so rule out carcinoma. Now, I'm often asked when Vimentin and EMA, when you do, supposing it's focally positive, which one is it that we should take? So from one of the different webinars I've attended, one thing which struck out was that they said, if it is CK is diffusely positive and Vimentin is focally positive, it's a carcinoma. CK is diffusely, I mean CK is focally positive, Vimentin is diffusely positive. First thing sarcoma. Of course, aberrations can be there. Then focal area in a reactive lesion or benign tumor, that also needs to be ruled out, especially when there are pleomorphic cells. Then small biopsy samples. Please remember to rule out initially itself, is it representative? Talk to the clinician, talk to the radiologist. Adjacent inflammatory response could have been biopsied or the adipose tissue around it. Then as I told earlier, lower grade on biopsy, different morphology on the excision specimen, undifferentiated areas only may be sampled. Then whenever, after all these things, you're still in doubt, then categorize first, whether it's benign, reactive, intermediate, or malignant. Give a descriptive diagnosis. You can say malignant spindle cell tumors and the options, like I'm thinking of possibility of synovial sarcoma, bar MPN, malignant peripheral nerve sheath tumor to be considered. Now, yeah, that brings me to another point before I end off. Please remember, your MPN-ST will show pleomorphic cells also. Synovial sarcoma, it is bland. It looks deceptively bland. Then one more thing I learned was this: all these translocation associated tumors look deceptively bland, whereas your pleomorphism is usually associated with aneuploidy. I think I don't remember which webinar I had attended, but some wonderful webinars in which you get all this information. Then conservative diagnosis is always preferred on biopsy. So to summarize, what did we learn? First, we assess or confirm the plane of lesion as per the clinical radiological finding, then identify whether it's reactive or neoplastic. If it's neoplastic, you classify the tumor, then you give the appropriate differential diagnosis. Ancillary testing, including special stains. With special stains, if you can come to a diagnosis, then do so. Otherwise, ask for other immunohistochemistry and molecular testing. And finally, when everything is ready, then you report as per standard protocols in use at laboratory. So these are my references. Now, all these are excellent references. I think any of you have any doubts, you can always look up these references here. And besides that, I have put some of these, tutorial-like sessions also, which are good, as well as some videos are available on YouTube, which are good. Now, do I have time? So, actually, whatever all this, pardon me?
No, please go ahead, ma'am. No problem.
I have time, okay, because I have some more slides actually. If attendees are interested, I can continue with them. But before ending, I would like to really thank everyone for a patient hearing. Of course, I cannot see anyone, so I don't know whether it's been a patient hearing, but thank you so much. And my teachers, I had wonderful teachers. Actually, I'm always of the opinion that if there's excellent teaching going on, you have to be extremely lucky, and that helps a lot in development in pathology. And I like to tell everyone that pathology has chosen you, so be extremely happy for that. And it's a wonderful subject. I'm very passionate about it, and I love teaching my students, both undergraduates and postgraduates. And I'm very, very thankful to them for all their doubts, etc., which makes me read again and again and again. And of course, my family and team pathology, oncopathology at Yenepoya, very, very supportive of all my efforts till now. My other institutions where I have studied as well as worked, wonderful people, all. Thank you so much. But shall I proceed, or are you getting any responses whether I should proceed? Dr.
Proceed,
Archana
ma'am,
and
no
Dr.
problem.
Aditya?
Can you proceed, ma'am? We can go on for another 15 minutes, no issues.
Okay, fine. Thank you. So, bonus features now. So, let's have a look at them. So, certain superficial soft tissue tumors are there. The benign ones and the intermediate ones, we are not that much, bothered about. Of course, you should know it, but then malignant ones, excuse me, what we are bothered, because you should not think just because it's superficial, it's malignant. Remember, benign ones are usually less than 2 centimeters, and those below 5 centimeters, it could be a low-grade malignancy, or it could be benign or intermediate, but more than 5 centimeters, usually we say malignant one. And deep-seated, we usually call them, we think first of malignancy than before thinking of benign condition. But some of these can be, superficial. So angiosarcoma, dermatofibrosarcoma protuberans, this is obvious from the name dermato. It's actually, it comes to the intermediate category now. Then epithelioid sarcoma. Now this epithelioid sarcoma, your classical variant will look exactly like a granuloma. So be very careful. It occurs in the superficial soft tissue. You may think it is granuloma, but the necrosis that you get in the center is fibrinoid, that is dense pink, not the kind of, caseous necrosis like. That is one point. And another thing is that this epithelioid sarcoma will have cytoplasm, the cell cytoplasm will be pink because it is epithelium-like, right? So it's like squamoid-like cytoplasm, another thing. And yet another point is that sometimes those cells in epithelioid sarcoma will look exactly that slipper-shaped cell that you see, epithelioid cell that you see in granuloma. But along with that, you will get these spindle cells also. So be careful of that. And it has, as it goes deeper, it becomes nodular. Kaposi's sarcoma, of course, you will get that, intracytoplasmic vacuoles, and a lot of RBCs will be there. Then myxofibrosarcoma, I already told you the different vascular patterns, and pseudolipoblasts you will get, and pleomorphism you will get in a myxoid tumor, spindle and stellate shaped cells. Next is your hemorrhagic tumors. So why should you know about hemorrhagic tumors? I mean, hemorrhage can occur anywhere, but remember, these are predominant, you'll get a lot of hemorrhage in this. So don't think it's just hemorrhage and not give more sections. If there are any gray, white areas or yellow areas, kindly give sections from that, because you need to rule out these conditions. Lymph node metastasis, yes. Now this actually, you can remember it by races, okay? So rhabdomyosarcoma, angiosarcoma, clear cell sarcoma, then epithelioid sarcoma and synovial sarcoma. So these sarcomas race to the lymph node. Remember it that way. So the sarcomas that race to the lymph node are the races one, that is rhabdomyosarcoma, angiosarcoma, epithelioid sarcoma, clear cell sarcoma and synovial sarcoma. And of course, scoring of your FNC, LCC, different scores are there. So the well-differentiated liposarcoma, fibrosarcoma, leiomyosarcoma and malignant neurofibroma come under score 1. Then score 2 is the myxoid liposarcoma, then conventional leiomyosarcoma, fibrosarcoma and myxofibrosarcoma. Score 3 are all the others, except for those which I told you that the scoring is not important. So that finishes my talk. Okay. This, yeah, a little bit about immunohistochemistry. Vascular tumors are always CD34 positive. Remember that. So also epithelioid sarcoma. Then your spindle cell lipoma and pleomorphic lipoma, the spindle cells in that will be positive. Picomas are also normally positive. Now here there are a lot of spindle cell tumors. DFSP, giant cell fibroblastoma, your solitary fibrous tumor, neurofibroma and gastrointestinal stromal tumor. These are all CD34 positive. But remember, I told you that solitary fibrous tumor, wherever it's there, synovial sarcoma is there, this is one place where it lays it alone. That is CD34 positivity. MDM2 is positive in liposarcoma and osteosarcoma. Liposarcoma, myxoid liposarcoma, it's negative, but well differentiated and dedifferentiated liposarcoma, it's positive. Osteosarcoma, the low grade ones are usually positive. Then you have CD99, loss of INI1 and S100. CD99 positivity, of course, solitary fibrous tumor and synovial sarcoma. Then the Ewing's PNET group, all are positive. Ewing's is diffuse, strong, membranous positivity of CD99. The others are not as strongly positive as Ewing's. Perineurioma and neurothecoma also. Loss of INI1 is usually seen in anything with rhabdoid morphology. So malignant rhabdoid tumor, then epithelioid sarcoma, proximal type alone will show loss of INI1, not the classical type, epithelioid MPNST and extraskeletal myxoid chondrosarcoma. S100, we all know, neural tumors as I told you. Then chondrocytic tumors can also be positive, adipocytic tumors can be positive, and myoepithelial tumors positive. Now neural tumors, remember, benign neural tumors are positive more. The malignant one has very less or focal positivity. You need to do the entire panel of your IHC markers, that is S100. Also you need to do, then I told you that histone complex, that is H3, your K27, ME3, that also you can do. This that one is actually also positive in malignant melanoma and meningioma, but morphology will help you in differentiating it from MPNST. So now cytokeratin positive tumors, angiosarcoma, your epithelioid sarcoma, it's got epithelium like both of them, so that's easier to remember. Epithelioid sarcoma, and I told you it looks almost like squamous cell. Now epithelioid hemangioendothelioma, also myepithelial tumors, synovial sarcoma and angiosarcoma, definitely positive for cytokeratin. Sometimes you can get cytokeratin positivity in other tumors, Ewing sarcoma, leiomyosarcoma, melanoma, peanut, then rhabdomyosarcoma. So this is the initial panel which I had already shown you. So that completes the session. Thank you.
We have one question from Dr. Shruti.
Yeah.
She wants to know about true and pseudo rosettes.
Yeah, true rosettes. Okay, true rosettes will have a luminal lining, whereas your these are known as flexnum intestinal rosettes, whereas pseudo rosettes are the humerite rosettes with neuropile in the center. Actually, in there is one more thing known as florets, which looks like a bunch of flowers that's seen in retinoblastoma alone. This is another type of rosette. Any others?
Shruti,
Shall I
hope
stop
it's clear.
sharing?
There are a lot of comments, ma'am, a lot of appreciations, and
Oh my
we
God,
had
people
close.
sat and listened through the whole thing.
Yes, ma'am.
I
We
am
had
so
close to
happy. Thank you so
160
much.
delegates today.
Pardon?
We had close to 160 delegates today.
Okay. Thank you so much.
Thank you, ma'am. That was really excellent, and we learned a lot, very informative, and we could clearly see the passion for teaching and passion for pathology in your session today. Thank you so much, ma'am.
Okay, thank you.
Dear delegates, we'll wind up now, and thank you so much for joining us this Saturday evening, and have a great weekend ahead.
Thank you to the organizers for having invited me to this wonderful platform. I never even dreamt that I would be one of the speakers. Actually, I have listened to most of your this one. It's actually a wonderful thing that you have done for us, for all of us, and making us listen to so many eminent personalities in the field. Of course, excluding me, I mean the others. It was wonderful. Thank you so much.
Dr. Aditya, we'll wind up. Yeah.
Thank you all. With that, we'll be closing the session. Thank you, ma'am, for that excellent talk. We all learned a lot today.
Thank